Dear audience, dear friends, we would like to welcome you to watch this video of Onco-Aging workshop, supported by EUniWelll, European University for Wellbeing, University of Cologne, and their partner universities and organizations. As we know, age is a well-recognized risk factor for cancer. People over the age of 65 represent a majority of cancer diagnoses. This is a significant need to prepare for this growing public health challenge. We invited national and international speakers from a multidisciplinary background to discuss new aspects of treating and caring on cancer patients with old age. Professor Maria Cristina Polidori and I will be the host of the event. Please follow our agenda here and wish you a pleasant visual tour and enjoy our workshop.
Why do we do this? So Beverly told me I have to be quick, and I know because we have to give the floor to wonderful speakers today. And so these are the speakers. I would just show in very few seconds what it is about and why we decide to do that. So what we did was a great thing, thanks to Beverly and her ability to be so patient with us and to allow people to be creative. We invited an actress, a bilingual actress, with simulating a chronological age. She's 65 all the times, but she simulated for 3 times 3 different scenarios of younger, same, and older biological age. Just a few seconds of an insight for this. This is the one scenario. This is the second. And this is the third one. Okay, so that was it already. What did we want to say? We wanted to say in the first case, 65 years old chronologically, also biologically. In the second scenario, 65 years old chronologically, and then much older biologically. Third scenario, much younger biologically. This makes huge differences in the management of these people, and we have to know about these differences. So the best thing is to co-manage internal medicine, surgery, together with aging medical doctors, neurologists together. So Professor Jacobs is a neurogeriatrician. Dr. Goede is oncologist and geriatrician. This beautiful miracle of co-management, and that's why EUniWelll enabled these beautiful things of interdisciplinarity. And this is a very international work and a very international workshop. So we are very happy to do this together with you. Thanks to all of those who accepted to be here today. We will record. That's why we will also disseminate, because we started not last year to prepare this. It was quite a short notice. So we will disseminate also this event. And now, Beverly, please just introduce the first speaker. And thank you very much for being so constant with us and wanted to do this as non-geriatrician to improve the care of older people. Thank you.
Thank you so much, Professor Polidori. So this is really my great pleasure, to be here. That I think it's not easy actually to make during the pandemic time, but in the end it worked. So after more than 1 year's effort together, so we are able to put all these things together. And today we are able to have the participants from, I would say, all of the world. So even it's now a small population to be here. First, I have to introduce our first speaker. So Dr. Najia Musolino. So I'm actually very happy, that she could offer her precious time to be here. So Dr. Musolino was the CEO of the International Society of the Geriatric Oncology. So she actually takes care of various leadership roles in the field of global health. And she's widely recognized for the developing and resourcing and managing global collaborations and teams. So for this expertise together with the oncology and global health together. So therefore, for me, actually, I learned a lot, from the SIOG. And I think it's also due to our seed funding projects able for me to connect with Najia for your fantastic organization. So therefore, today I'm very happy that to invite Dr. Musolino to be here to introduce you about SIOG and also the story.
Thank you very much, Dr. Zhao, Dr. Polidori. Thank you very much for the invitation. It's an honor for me and also a great privilege to come and meet many of you whom I already know from our SIOG network, and also meet new experts and very passionate and dedicated individuals in the field of cancer and aging. A very much needed topic for the future years, I would say. So before I start, I'm just going to maybe take a few seconds to share my screen. I have a few slides to share with you today. Dr. Zhao, is my screen visible?
Yes.
Wonderful.
Yeah, perfect.
So I am Najia Musolino. I'm connected today from the SIOG head office. We are based in Geneva. I serve as the Chief Executive Officer, and SIOG basically is the French acronym for the International Society of Geriatric Oncology. So SIOG, as many of you would know already, is a not-for-profit medical association. In 2020, SIOG celebrated its 20th anniversary, and actually you would see here from the flags that were hoisted up at the Lake Geneva. And ever since, SIOG has welcomed over 2,000 active members who have contributed to the main advances in the field of geriatric oncology. And this has been over in over 84 different countries worldwide. So I would, before starting, I would like to really thank, on behalf of SIOG, EUniWelll, the project, and Dr. Zhao and Dr. Polidori, for this opportunity to be here with you and to learn about the important achievements of EUniWelll and from the discussions we will have later on this afternoon together. So if I, why geriatric oncology? Dr. Polidori made a slight suggestion to it, and we all know that the world population is aging, and this is thanks to the global improvements in the healthcare systems everywhere, even in low middle income countries. Sometimes, if you look into the advances, there have been a lot of advances worldwide. But advancing age comes with a higher risk of cancer, and in developed countries mostly, half of the cancers already occur in patients aged 70 and above. Why SIOG? So there was this beautiful ASCO post that came up recently, which talked about the history and the rationale behind the creation of SIOG. So I would say the legacy of SIOG was built by these like-minded individuals like yourselves, who back in the 1990s, when they were in the middle of this talks and advances for explosive research and understandings in the field of aging and cancer, they came together and they thought there was a need to create a network that was really dedicated to the care and treatment of patients, older citizens that were suffering from cancer. This happened in the year 2000 when SIOG was created formally in New York. And then from there on, 25 years thereon, we had members from all backgrounds coming in and joining the network to really contribute to the clinical developments, to the research that was put forward for the advancements and progress in health systems for cancer and aging. And finally, today, when we look back at SIOG, we see that it has not only been the contribution of oncologists who were the first healthcare professionals really interacting and seeing and welcoming the older citizens with cancer, but today SIOG is a network of multidisciplinary teams coming in from every sector. I would actually go from the medical oncologists to surgeons, to radiotherapists, to nurses and allied health, to scientists who have all come together to contribute to the advances. So at SIOG, we basically have a number of activities. First of all, our main focus is science and education. Education is key, really, in understanding, and I would say also in deciphering the challenges, the gaps that are still existing in the healthcare systems when we talk about care and treatment for cancer in older patients. So we have our flagship products, which are the SIOG advanced courses in geriatric oncology that are delivered on an annual basis. These are CME accredited courses that help young professionals to sort of understand the treatment and care of older patients when they sort of handle these cases in their respective institutions. We also have task forces and publications on numerous topics, on numerous tumor types that affect the older patients. And most of our publications basically go in the official journal of SIOG, which is the Journal of Geriatric Oncology. I would invite you to go and visit JGO to find out a number of very, very interesting articles, peer-reviewed publications that come up for cancer and aging. We also have a very strong membership worldwide. Our SIOG national representatives and committees work together to strengthen the link between the leadership, which is based at the SIOG headquarters, with the different institutions worldwide, going from the public sector to government institutions down to the individuals. So our forte, as I mentioned, is an international network. We have national representatives in many parts of the world. You would see that Africa is not represented because aging is not really one of the key priorities yet in Africa. It's a fairly young continent, so it has not been really coming up yet on the map, but hopefully it will stay this way. But yes, for now, most of the works are in North America and Latin America, also in Asia Pacific and Europe, mostly. Over the years, we have noticed that many young professionals have been very keen, showing interest in joining SIOG. And we actually thought it was time that we created an interest group specifically for the younger professionals who are the next generation of leaders in geriatric oncology. So we have a young SIOG interest group within SIOG that is this vibrant community of, again, young, like-minded young professionals that come together and deliver a number of very, very impactful outputs in geriatric oncology. These are from, organizing sessions at the SIOG annual conference, to their own blog. They're very active in writing reports and publications. And newsletters are very, very informative. They have their own forum where they meet and discuss various topics in geriatric oncology, and also professional development of the network of the younger professionals in the area. Their publications are numerous, and their webinars are also very, very useful in terms of addressing specific topics, hot topics that come up. I would give you an example of the COVID situation where the care for older cancer patients were actually discussed extensively during the pandemic. These recordings are also available on the SIOG website as resources, so feel free to access them. They are free of charge and accessible to anyone that visits the SIOG website. So we are really trying to build a multidisciplinary and international network. And for this, we welcome members from around the world. We have individual membership possibilities, also institutional membership. So if the public institutes would want to become members and offer the resources and the professional network of SIOG to their staff and to their institutions, they are welcome to visit the website and join the network. And for this year, we have the annual conference coming up at SIOG, where we'll have different sessions, we have different tracks. So do visit our website, please submit your abstracts. Join us for the conversations in Geneva. Geneva is a lovely town of international institutions, and it's a vibrant community. And obviously, many of the legacy founders of SIOG are also from Switzerland. So we'll be delighted to welcome you in Geneva from the 28th to the 30th of October. Because we're coming to Geneva, we would also have a public policy meeting at the United Nations. So this is really to focus on the public policy arm of geriatric oncology, so that we can support the ministries of health in their national cancer plans in promoting and really advancing the field of geriatric oncology for the care and treatment of older citizens. So if you're interested to join our public policy meeting also, please feel free to visit the website. The meeting is free of charge. You just have to register and attend the meeting at the United Nations. I think I've come to the end of my presentation. I would like to thank you once again for your kind attention and the opportunity to speak with you here. If you require any further information, please do write to us, and I'll be here available for any further questions. Thank you very much for your attention.
Thank you so much, Dr. Musolino. This is, I would say, our project was also developing, under the guidance from the SIOG. So therefore, it's also very nice for you to introduce overall of the organization here to the new audience. Thank you so much.
So we decided with Beverly that if there are no urgent questions immediately, we would like to keep the discussion at the end open for all the talks. So I don't see any further comment or question. Thank you very much also from my side. So we have the good overview of what is possible in this field and how many exchanges and initiatives are going on. This is really important. Good. So, Barry, if you give me the okay, I would go ahead. And would you like to share? I don't want to make any mistakes. I don't. It's right that Professor Jakob is speaking now, right?
Yes. Yeah.
Very good. So then we move to the next speaker, and it's also very good for us. It's really, thank you very much, Andreas, to have here Professor Jacobs. Professor Jacobs is a board-certified neurologist and geriatrician with specific training in brain imaging based on positron emission tomography, on PET. He worked on indirect localization and quantification of gene expression and gene regulation in the brain, and used this technology for imaging gene and cell-based therapies for various brain disorders, including tumors. That's why he's here today. He uses multimodal molecular imaging technologies to developing imaging-guided patient-tailored diagnosis and treatment strategies in neuro-oncology and neuroinflammation associated with stroke and neurodegeneration, so Alzheimer's disease or Parkinson's disease. He would like to understand how the brain's microglia cells contribute to aging, specifically to the age-related phenomenon of sarcopenia. In the field of clinical geriatric medicine, it focuses on neurogeriatric aspects on functional decline with age and its impact in clinical decision-making. So this is really important for us. I didn't know this by heart, but I can summarize in saying that I know Andreas since many years, since I'm in Germany, and he's a great, not only geriatrician, but also neurologist, and as such, he's part of the so-called Geriatrics task force, which was newly established in Germany together with Richard Dodel in Essen and Walter Metzler in Kiel, to enable this kind of co-management of improving, in this case, between neurological and geriatrics, the management for patients, for older patients affected by neurological disorders, which need, of course, a specific expertise, and that's why I'm stressing this fact of co-management, which is really everything in advanced age. Andreas, I would have to talk much about you, but just go ahead. You please have the floor and tell us about your interesting data. Thank you.
Okay, Christina, thank you very much for this very nice introduction. Barry and Christina, thank you very much for giving me the opportunity to be part of this seminar today in the afternoon. So I will talk. So actually, Mrs. Musolino, I'm sorry. You ended with the phrasing "for a better outcome." So I would like to continue in this sense for a better outcome with regards to the question, how can we do a smart decision making in an old person who may be frail, who get cancer? What's the best way of treatment for this patient? And to answer this question is we need to know exactly basically his functional status. So therefore we need assessment methods for decision making to guide our decisions in such a way that in one person we do chemotherapy and in the other we do not. So can we use geriatric assessment for toxicity prediction in older cancer patients? That's the topic. And of course, you know all these graphs where we are aware of that cancer is a disease of the old people. So with increasing age, we get the probability to get cancer is increasing. And of course, in the one hand, which we have in hand is that we do prevention. So early detection as much as possible so that we can eliminate early disease. But if we get really a disease, then we have to make a good decision with regards to functionality. I would like to start with two hypotheses which are very well accepted. The first hypothesis from Najia was that at advanced age, we need special decision making similar as we do this in the pediatric group. And then with Marjorie Warren, who indicated, well, a doctor alone is not enough. We need a multidisciplinary team. We need not only medical treatment, we need the mobilization aspect, we need to respect social aspects, and of course we need functional aspects. And these functional aspects, from my point of view, and this is now a new hypothesis, is that the functional aspects in geriatrics are much more are really heavily dependent on the functional status of our neuronal system, the central and peripheral neuronal system. And I will go a little bit into this. And therefore, from my point of view, for a geriatrician, there is certain neurological know-how necessary to really get a good assessment of functionality in the advanced age. And of course, we all aware of that there is a high research demands in the various fields of geriatric to advance our field. Now, I don't want to read through the EU EMS definition of geriatrics, just to show the buzzwords physical, mental, functional, social, multiple pathology, holistic approach, multidisciplinary, optimized functional status, improve quality of life. So all this can, from my point of view, be summarized in we need to focus on function. And we need to focus on function with regards to outcome in oncological treatment, but also with regards to can an older person really take the probably toxic therapy for within an oncological treatment. So what is function? Function is basically the 4 L's of life: locomotion, learning, loving, laughing. Locomotion stands for everything which is related to motor function, learning, of course, to cognitive function, and loving and laughing is everything with regards to basically our mood, our happiness in life. So we need these basic mechanisms for assessing whether a therapy for a patient is good or bad. If we have a therapy which impacts these parameters, then we have to be very careful. And the reason why I became a geriatrician as a neurologist is because all these 4 L's of life are, of course, heavily influenced by the function of our central nervous system. Now, as we grow up, we gain function, age-dependent gain of function, and when we get older, we lose function, age-dependent loss of function, gain and loss of function, not in terms of genetics, but in terms of our human function in our life. And of course, all is basically the main goal is to stay independent as long as possible and to have respective quality of life as long as possible, despite a disease or despite a therapy. Now, with regards to, I have shown you this line before. This is the growing incidence of, for example, cancer. This also relates, this also holds true for stroke or heart attack or whatever disease. So, but cancer is an age-dependent disease, so the incidence grows with when we get older. At the same time, we lose not only function, so that we get dependency somehow, but also we also have a decreased organ function. So decreased function of heart, lung, kidney, and so on. So when we plot this in this type of graph, then we will see that the open therapy window to initiate a good therapy for a certain patient decreases because our dependency is too big or our organ function is too heavily reduced. And with whatever we do, we have to somehow estimate, calculate, or quantify where the patient lies within this open therapeutic window for his disease. Here is the general approach, what we do in geriatric medicine. So when we get older and get multiple diseases and multiple medications, we go up in this basically line to get more and more dependent. And what we do with geriatric medicine is that, of course, we have to intervene with the active comorbidities. We always have to work on in the field of medication to optimize polymedication. We have to work in the field of nutrition and physiotherapy, and of course, the management of environmental factors. And to just show one of my favorite pictures is depicted here. This shows the white matter lesions of an 80-year-old who has some decrease in motor function and some decrease in cognitive function. Of course, this is easily understood because he has lost substantial parts of his network, of his brain network, which constitute of 10 billion neuronal cells, and each neuronal cell is connected to 1,000 other cells. So this neuronal network is heavily basically disturbed by these white matter lesions and probably also by loss of some neuronal cells. And we can quantify this loss of neuronal function by the assessment of motor function, cognitive function, as well as basically our mood system also. And so this is what has always been respected when we do any type of treatment of old patients or of old people. And when you see this type of pictures, I would like to show just one slide of basic pathophysiology, which probably holds true in many, many instances at the old age, which is this cartoon here. So at old age, what happens is that the blood-brain barrier gets disturbed. So normally the blood-brain barrier is quite tight, so that you have a quite preserved constitution of the neuronal network together with the microglial system and so on. Now, at old age, the blood-brain barrier is disturbed in such a way that cytokines, whatever sources of, get into the brain and will have an impact on microglial function. Microglia are extremely important for our neuronal network. It is not only important for neuronal regeneration, but also for network formation, for synapse formation, for long-term potentiation, for learning and so on. And if we disturb this microglial function, we have an impact, a negative impact on all these pathophysiological mechanisms in the brain. And a very simple disease is a urinary tract infection or a pneumonia, which releases cytokines to the blood system, to the systemic blood system, which then disturb our neuronal function. That's the reason why older people fall, not only because they haven't hit the light when they go to the toilet at night, but also because the neuronal function is not as proper anymore when they have a urinary tract infection. And my hypothesis is that the same holds true also, and I don't know whether there are any investigations out there, but this holds also true when you do active treatment of systemic cancer disease. You have, of course, you work against the cancer, and with this type of therapy, you basically elicit is also more or less systemic immune response against the cancer, which then will have an impact on the microglial and functional system of the central nervous system, especially in the old age group. And therefore, we have to respect this. Now, when we do physical training in the older age people, we intervene with this pathophysiological system at different points, not only with regards to strengthening the muscle, but also with regards to intervening with the inflammatory system, the circulating regular T cells, but also macrophages in the adipose tissue, and so on. So we will have an impact on our systemic inflammatory response, and therefore it is very important from my point of view that we have to respect the physical training at old age in whatever disease stages this patient is. Now, of course, I have indicated already in geriatrics, we are not treating with the doctor and the nurse alone. We have a multidisciplinary team as originally proposed by Major Warren. But now we, in addition, need not only multidisciplinary, we also need interdisciplinary teams. So we need to bring together the expert geriatricians with focused specialists, for example, the oncologist or the neurologist or whatever. And one example is given in the next slide, but before I go, I have to, I first have to go into this slide. So when you have just the multidisciplinary team, we have seen that multidisciplinary team care has an impact on outcome. Yeah, here primary endpoint living at home is only related when you work in this type of multidisciplinary team. Now, there are new reports also when we work in an interdisciplinary way from geriatricians, for example, together with the orthopedic surgeons. You get in significant impact on the functional outcome when you do combined care and not only care of the orthopedics alone or the geriatricians alone. And the same holds obviously true also when we bring the oncologists together with geriatricians. And we have performed a relatively small study here in our hospital where we wanted to, because we have a really huge oncology group with Professor Ko, and we wanted to investigate whether we can measure or can predict chemotherapy-induced toxicity in cancer patients by any of the scoring systems. And I assume that you as oncologists are all aware of these scoring systems, just to indicate that the CRASH score basically notes what type of chemotherapeutic intervention is planned. It has some parameters to predict hematological risk and some parameters to predict the non-hematological risks. And this scoring system, the so-called chemotherapy risk assessment scale for high-age patients, was originally proposed by by Professor Exterman. And then the therapy-associated toxicity that is then quantified as low or high or middle. And the CARG score has 14 parameters. And here you basically divide into therapy-associated toxicity between low, middle, and high. And so what we did was we first performed a pilot study, and then we performed a dedicated study on 120 patients to basically compare the value of risk prediction by these two scoring systems in comparison to normal clinical assessment. And here you can see the inclusion criteria, people older than 70 with a cancer diagnosis, speaking German, and with a planned antineoplastic therapy first line. And the exclusion criteria was that there was already an ongoing antineoplastic therapy or gross impairment of cognition. So the study design was when a patient agreed to be included in the study, both scoring systems were performed. Then we basically rated at that time already, made our risk prediction. Afterwards, the patient would receive the therapy, and then we would quantify the CTCAE grades 3 and 4. And what we found was the following. We found on the one hand that with both scoring systems, you have a quite nice toxicity prediction with regards to grade 3 and 4 toxicity with CARG and CRASH, which is obviously better than just the clinical scoring. And I would like to underline this. I thought when we started with the study, we wouldn't get this result because I thought that our oncologists were very, very good because they have really, I mean, they are really experienced oncologists, okay? But obviously the clinical prediction of toxicity is not as good as these scoring systems. So the one answer is, of our study is that one really should include scoring when we do clinical treatments in oncology at old age. And the second issue is that here is depicted here that we have some overlap between the CARG and the CRASH, but it is not a real good overlap. So we have, of course, a partial overlap that with a low CARG score, we have the highest fraction on the low crash score, and vice versa also for the high scores. But we also have some disagreements in between. That means that the crash and the CARG score are somehow also complementary to each other. So if you want to have a really good answer, you need to do the two scorings. And if you, and I come to this here in my summary, so crash and CARG have similar predictive values for overall toxicity or the non-hematological toxicity. The CARG score is relatively fast. So if you are just interested in overall toxicity, then you can do a fast CARG score. If you also want to have a prediction on hematological toxicity, you have to do the crash score. And from my point of view, if you, in certain instances, it is wise to basically perform both scoring systems. And both scoring systems are much better than the clinical assessment alone. So with this, I would like to expand my conclusion a little bit to this cartoon. So from my point of view, in the past, geriatrics, the field of geriatrics were supposed to know everything. So the multidisciplinary team was supposed to do and to know everything. And from my point of view, this view has to be expanded. I think we need a really good interconnection with the field of oncology, with the field of cardiology, with the field of neurology. We have this interrelation already in the field of gerontopsychiatry for many, many years. This is out of question, and also with regards to the field of urology. So we need this interdisciplinary work in certain instances to improve the outcome. And of course, for this, we need basic research, clinical research, and the formation of centers of aging medicine. And all this is with the only aim to improve the outcome for the patient. Yeah, actually, this is a slide which I always show in Germany. From my point of view, the German society is very, very bad with regards to taking care of their older people, because we never question that there is a one-to-one taking care of our kids, the one-to-one ratio for taking care of our kids. But from my point of view, we have to learn in our rich societies, we have to learn that this is again necessary also at the advanced age. And we have to put money and smart ideas in how we can basically serve a one-to-one taking care network for our older people in our society. So with this, I would like to thank you for your attention, and I hope I'm not too much over time.
No, Andreas, you are not, and even if you were, we would, be happy to have a little bit of more time for these important things that you just presented to us, which, yes, are very really targeting the very core of the meeting of today, the very core of Onco-Geriatrics, and the very core of EUniWelll initiatives with Onco-Aging. So thank you very much. And I would just like to comment 1 second that in the last slide to the previous to the last, when you show the interaction between disciplines and geriatrics, and you do it, we achieve it through basic research and clinical research. Thank you. You could act on the top or on the bottom or wherever you want. One of the pillars to achieving this is education. So to teach the young doctors or medical students immediately, as soon as possible, because they don't have time to go into oncology and suddenly seeing that they have to learn geriatrics, because now the demographic changes now. And after 2040, we will have a completely different world population. So it's really important. But it was really enlightening. Thank you very much. And if are there any acute questions, one or two very short questions, because otherwise we would move the discussion to the end. And I would move. Thank you very much, Andreas. I don't see any questions. Basically, just to make sure that you can also write in the chat, and either Beverly or myself will pick up your questions. So somebody, yes, so Dr. Musolino says, yes, the complex change management required will not happen organically, and the education will be, of course, the sum of of course, together with the pillars of clinical healthcare and basic research. You are right. So it's once again bridging the gap between the many aspects of medicine and education. Great. So thank you very much. And I have the pleasure to keep moderating also for the next speaker, Dr. Valentin Goede, who's also a specialist that I know since a couple of years, less time than Professor Jacobs, but still we work together since a couple of years at the University of Cologne with Valentin. Dr. Goede is an hemato-oncologist and clinical geriatrician and head of the Department of Onco-Geriatrics at the St. Marian Hospital in Cologne in Germany, which, for those of you who don't know, it's one of the largest geriatric clinics in Germany. And his research is on the delivery of geriatric care to older inpatients with the active hematologic or oncologic malignancies, and also frailty, and also related to the high burden of geriatric syndromes. Dr. Goede is also a member of the German chronic lymphocytic leukemia study group with a research focus on CLL in older patients, and is also an active member of the European Hematology Association, board member and vice president of the European Hematology Association Hematology and Aging Scientific Working Group, and also a member of the International Society of Geriatric Oncology. Dr. Goede published many articles, very high impact journals, and he always focuses also from an educational point of view on these fragility aspects of older patients when they have such stressors like tumors. So Valentin, the floor is yours. Thank you very much for having accepted. You are also in the scientific advisory board of the Onco-Aging project. So we're very happy to have you here. Thank you.
Thank you very much, Christina, for the kind introduction. I hope that you can see the screen and the slides.
Yes.
So I think the previous speaker, Andreas, already provided the perfect background information for today's discussion. So I have only one conceptual slide at the beginning. What you see here as a figure is the well-known frailty stressor paradigm, which can also be applied, of course, to the geriatric oncology field. So the patients we are talking about today, they do not only have their cancer disease and their cancer therapy, for example, chemotherapy, but they also have underwent physiological aging with the changes that go along with this, as depicted by Andreas just a few minutes ago, and they have chronic diseases. These factors, of course, contribute to their increased vulnerability or frailty. And what we usually see that's in the further trajectory here shown is that interaction between frailty and the cancer disease or therapy as a stressor, leading to quite complex interactions and at the end to adverse health events, for example, toxicity, chemotoxicity, for example, but also intercurrent diseases independent from the original cancer disease. And ultimately, these people may encounter a very poor health status. And then, of course, they are threatened to lose their autonomy, but also to become untreatable for their cancer. And of course, they are then quite in danger to experience earlier death. So how to approach frailty in these patients? We have already learned that we have a predictive approach. We can try to assess frailty, and we have already learned that functional impairments, geriatric impairments are very important, and that's why geriatric assessment is broadly accepted as a method to assess frailty, also in oncological patients. And we have seen that example that Andreas has provided with the toxicity scores that are available. The more easier one, I would agree, is the CARG score. And we have already seen that geriatric impairments or functional impairments that are included in this CARG score, for example, that they are relevant for the toxicity risk at the end of these patients. Now, of course, we can do the geriatric assessment. We can predict the risks of adverse health events, such as toxicity, and then we can modify the stressor here, the cancer therapy, for example, by using milder treatment regimens, by using a lower dosage of chemotherapy, for example, and so on and so forth. We can do that, and hopefully we can prevent then this adverse trajectory in the further course of the treatment. However, we will encounter, of course, patients that still will get into this poor health status. And at this stage here, we have still the possibility to intervene, to do a geriatric intervention in order maybe to restore autonomy and to keep them, patients, in their treatment. That's the specialty of my department here, to treat patients at this stage. So I see a lot of patients that have ECOG performance status 3 or 4. Their CARG scores are sky high. They all have a risk of over 90% or 90% for further chemotoxicity. And I can tell you it's quite hard to treat these patients. When you treat these patients in general geriatric departments, there are some reports from France, for example, mortality is quite high. The in-hospital mortality it's close to 25% actually. So it's a quite huge challenge, and the border to palliative treatment is very thin. So it might be smarter to intervene earlier. And that's actually the original purpose of geriatric assessment, not just to predict something and to do prognosis, but also to use this information for provide targeted geriatric interventions at the earliest point. And today I just want to provide you with recent study evidence that came out during the last 24 months or so. And that, in my view, is very important and probably practice changing in the field of geriatric oncology. And I will just discuss with you briefly, of course, 3 of these studies that in my view are quite important and will guide also the landscape of care of these patients in the very next future. So the first study I would like to mention is this one here. That's a so-called GAP 70+ study that was published in the Lancet only months ago. And if you look very closely to the authors here, you will also spot here Melissa Lowe as one of the co-authors. So if you have any detailed questions for the study, then probably she would be the right person to ask. And I will not provide an in-depth scientific review of the study here. I just would like to make you familiar with the general concept and the key result, which is, of course, the most important. So in this study, patients 70 years old or older with incurable cancer or lymphoma were included. And all of these patients were treated in oncology practices. So clearly outpatient individuals here. And then these practices were put into clusters, and these clusters were randomized, but that's not the important thing. So it's a randomized study, and in the experimental arm, geriatric assessment in these patients was done, and then GA-based intervention recommendations were made to the oncologist, to the treating oncologist, together with a geriatric assessment summary. Whereas in the control arm, a geriatric assessment was done, but the oncologists were not provided with the geriatric assessment summary, nor were they provided with intervention recommendations. And the primary endpoint was then the rate of grade 3 to 5 treatment toxicity, so severe chemotoxicity over the first 3 months of treatment during that palliative systemic treatment setting. And just to give you an impression what was the study intervention in that trial here, so you can see that in the geriatric assessment performed here, most of the well-known geriatric domains were addressed, like functional status and cognition and so on. And the tools that have been used were straightforward and very close to what is recommended in, for example, the ASCO geriatric oncology guideline. And these are just examples what recommendations were made based on certain cutoffs that were set for all of these instruments here. So for example, if a patient had abnormal results in the physical performance assessment tools, then for example, referral to a physical therapist was recommended, and so on and so forth. So the patients that were included in this trial were close to 80 years old, and you can see here in these patients' characteristics that around 1/3 or so was even over 80 years old. So I would say this study clearly targeted not just an older patient population, but also let's say geriatric patients. And on the right side, you see here the most frequent tumor types in this study. So a lot of lung cancer and a lot of gastrointestinal or genitourinary tumors. And this is the key study result, actually. So what has been observed here is that in the experimental arm, in the geriatric assessment and intervention group, 50% of the patients experienced grade 3 to 5 toxic effects, whereas this rate was higher in the usual care group. It was around 70%, so an absolute risk reduction by 20%, and that concludes to a relative risk to 0.74. So the primary endpoint of that study was clearly met. And this forest plot just demonstrates or supports the primary result with the benefits seen across all of these subgroups here. You can see here that the relative risks are below 1 in all of these relevant subgroups. So the key study conclusion made by the authors in that Lancet publication was that geriatric assessment and assessment-guided management should be considered the standard of care for older patients with advanced cancer, starting a new treatment regimen with a high risk of toxicity. So that would be practice changing, because if you look to the current standard of care or routine care, then you will hardly find routinely done geriatric assessment in an oncology practice or geriatric intervention. That's not the case in many of the treatment settings, so that would be really practice changing. So for that, you may want further study support, and that exists, I would say. This second publication here is the GAIN study, I will briefly show you only here the key data. That's the study design. So in this study, patients with solid tumors of any stage were included. The patients were prior to the treatment of chemotherapy, and the patients were older than 64 years. And patients were randomized. Again, a large study. In the experimental arm, geriatric assessment was done, and geriatric assessment-based interventions were recommended and provided by a multidisciplinary team. We have just learned what a multidisciplinary team in geriatrics is, and in the control arm, this didn't happen. So the primary endpoint again was grade 3 to 5 treatment toxicity during chemotherapy, plus minus further medication with targeted drugs. And the study intervention was quite similar than in the other study, the Lancet study. Again, functional domains were looked at, and then deficits were identified, and interventions were recommended and also carried out. So the study population was a little bit younger than in the previous study. Median age was around 70 years, and the spectrum of tumors was a little bit different, but nothing special here. And again, the primary endpoint in that study here was met. You can see here that in the left column here, in the experimental treatment arm, the rate of severe chemotherapy-related toxic effects was again around 50%, whereas it was over 60% in the standard of care treatment arm. And these differences were also partly seen when you look to subgroups here. So again, a positive study. And the third and last study I just briefly would like to mention is the so-called Jericho study. That's a single-center study that was carried out not in the US, but in Denmark. So this was restricted to colorectal cancer patients after surgical resections that were planned for adjuvant or palliative chemotherapy. Patients were over 60, and they were selected for some frailty with a so-called G8 screening. And again, I think this is also true for the other two studies. ECOG performance score was still quite good, ranging from 0 to 2. So not patients that are confined to bed or something. And again, experimental versus control arm, geriatric assessment intervention versus standard of care. In this study, the primary endpoint was completion of chemotherapy without later dose reductions or delay. And again, in this study, a lot of the geriatric assessment tools were applied, and interventions based on the cutoffs here were then implemented and provided to the patients. Patients in that study were around 75 years old. I just told you that functional status was not that bad. And the distribution for adjuvant versus palliative treatment is shown here. And again, the study was positive. The primary endpoint in that smaller study here, the other two studies had more than 500 patients included. This study had 140 in total. But the primary endpoint was met, and patients receiving geriatric assessment and intervention, they completed the planned treatment with the initial dose more often than in the control arm. And as I told you, there were quite a lot of publications coming out from studies similar to those presented. So I have presented to you the GAPS 70 study, the GAIN study, and the Geriatric studies. There are results from other studies that sometimes did not meet their primary endpoint, but at least they were positive with regard to some secondary endpoints. And there were also a few studies that were unable to meet their primary endpoint. Nevertheless, of course, and as expected, no toxicity of the intervention was observed in these trials. So by doing geriatric assessment interventions, you obviously do no harm to your patients. So what does this mean? I think, well, we have evidence from retrospective and few prospective studies, let's say evidence level 3 or so, for predicting risks with geriatric assessment, but we have evidence level 1B or so, several RCTs now for this early geriatric intervention in a preventive supportive intention. So we have data supporting this. These data come from high quality RCTs, and they clearly show there are clinical benefits and you do not harm your patient. There are no toxic effects by this additional intervention. So what does this mean actually? That's my key message here. So I think we can say, as Andreas has nicely pointed out, geriatric assessment and interventions, they have, of course, their origin in geriatric medicine. But I think we have now a bunch of research demonstrating increasing evidence for the benefits of both geriatric assessment and intervention now, that's new, in oncological and hematological care. Well, what will be still a great challenge and also task is the implementation into routine clinical care. As I said to you, if you look to oncological centers, you will not always find already assessment and intervention being part of the routine care of those older patients there. And so if you are young and just start your career, I think this might be something where you can easily get involved with and try to improve this and thereby also improve, of course, the general care of those older, highly vulnerable oncological patients. Thank you very much for your attention.
Thank you very much, Valentin, for this beautiful presentation, which takes me to, I can't help, I have to comment that there is in medicine, it's known almost in every discipline, but particularly for aging medicine, the so-called know-do gap. We know it, but we don't do it. And this is incredibly important because we have to move in sharing our knowledge. And I think it's very important to have these meetings here, which then move towards the individual disciplines. So geriatricians have the tendency to talk among themselves how important geriatrics is, but we have the problem with the interface between with the internists or the organ medicine medical doctors, because we don't I mean we didn't structure our strategy in this sense. So one way would be probably that we offer our instruments and the possibility of co-management, and then the feasibility will be soon clear, because better care is always cheaper at the end. So there is no reason why we shouldn't use the multidimensional approach when we treat persons. Okay, so thank you very much. Acute questions to Dr. Goede? If not, then I would give the word back to Berry, who's going to present the next speaker, and please.
Yeah, actually, I'm very happy that with our workshop, we are able to invite Professor Dr. Melissa Law from the United States. So, and please allow me to introduce her. So Dr. Law is a geriatric hematologist with the broader certification in internal medicine, hematology, oncology, and geriatrics at the University of Rochester in the United States. So clinically, Dr. Law specialized in caring for older adults with the hematological malignancies. And she is the director of the Geriatric Hematology and Mobile Health Research Program, and also the director of the International Geriatric Oncology Research Observationship Programs of the Weymouth Cancer Institute. So Dr. Law's long-term goal is to become an independent clinical investigator, developing and implementation behavior interventions and use the mobile health technologies to improve the outcome for the older adults with the hematological malignancies. And besides, Dr. Law was also interested in so many different fields, and she's interested in studying mechanisms by which these interventions improve cancer and treatment-related toxicities, as well as the prognostic understanding for the older patient and their caregivers, as well as the treatment decision-making among the older patient with acute myeloid leukemia. And Dr. Law has received over 40 research and scholarship awards, and she also published over 120 publications in this field. Besides that, Dr. Law was also taking several leadership in the society, including the Young SIOG interest group, as well as the American Geriatric Society Cancer and Aging Research Specialists. So many very wonderful and important organizations for the cancer and aging research. So therefore, today I'm very happy that from the United States, so Professor Dr. Law, Melissa Law could give us her talk. Thank you very much, Melissa.
Thank you so much, Dr. Zhao, for the invitation. And let me share my slide here and hopefully you can see it. So the previous speaker, Dr. Jacobs and Dr. Goody, have really set up my talk really well. They've talked a lot about why we care about this population and recent study that support why we do geriatric assessment as well as intervention. So I'm going to specifically talk about how we do it at UC Rochester. We probably have the biggest geriatric oncology clinical program in the country, at least in the United States, and we have done it for the last 10 years or so. And then I'm going to go through some of the research locally that we're doing right now that focus on rehabilitation that Dr. Goldie had mentioned. And then because of my role in several organizations, I'm going to provide some really concrete things that younger generation can perhaps be involved if you're interested. And then obviously contact me if you're interested in joining any of these organization or initiative. So here's the outline of the talk. So I'll talk about the different models, at least in the United States, I believe worldwide as well, as far as I know. And then I'm going to focus on our clinic model. And again, talking about research specifically in geriatric hematology, because that's what I do, although we have 5 other investigators in other areas as well. So we have a wide variety of different research projects in different areas, both in solid tumors and blood cancer. And then briefly talk about the different activities and education initiative as part of the various organizations. I won't talk too much about SIOG because Ms. Musolino has talked a lot about that, but I will talk more about Young SIOG as I'm chairing that interest group. So talking about the models of geriatric hematology and oncology. So again, we know geriatric assessment helps, but we know also a lot of institutions and clinics do not have the resources to implement geriatric assessment as well as this intervention. So as of right now, there are 3 main models on how geriatric assessment is being implemented. The most common one I would say is probably a consultative geriatric assessment clinic, meaning you have a clinic already set up and the person, the physician in that clinic could be a physician trained in either oncology and geriatrics or hematology and geriatrics, which means they're trained in both specialty. So in Rochester, all of us are trained in geriatrics and oncology, and myself is also trained in hematology. You can also have a geriatrician. It doesn't have to be geriatric oncologist. You can partner with a geriatrician if you're an oncologist, or if you're a geriatrician, you partner with an oncologist, and you have two physicians in that clinic where you each have your own expertise. And Ohio State, for example, has this model. So the second model is a geriatrician actually embedded within a primary clinic. So Dana-Farber in Boston, for example, has a geriatrician that sits in the oncology clinic. And if they feel like geriatrician would be helpful for their patients, they have a geriatrician see the patient on the same day as part of the clinic. And then the third model is basically the oncologist or hematologist who is seeing the patient themselves. So they serve as the primary oncologist who is treating the patient. At the same time, they're also trained in geriatrics. So in their own patient, they perform geriatric assessment. So this is different from the consultative geriatric assessment clinic, where this patient usually are not their primary patients, meaning they are providing guidance and recommendation to another oncologist who is treating a patient, whereas primary management by dual-trained geriatric hematologist oncologist, you serve as an oncologist, but at the same time, you also perform geriatric assessment. So in my case, I do both. So I have a half-day clinic where I provide consultation to other hematologists. At the same time, in my clinic, I also do geriatric assessment to patients that I think would be appropriate. There are some institutions who have inpatient geriatric hematology oncology services. Those are not common because I think we feel like inpatient consults, often when patients are in the hospital, it doesn't necessarily reflect how they look in the outpatient setting. So geriatric assessment may not be that helpful, but there are institutions who have created this model. So the three common outpatient models are the first three, and then sometimes you'll see the inpatient models as well. So talking a little bit about the University of Rochester model, before I start though, I do want to show people where Rochester is because most people do not know where we are. So I'll start with, most people know where New York City is. This is Boston, and here we are in Rochester. So we are in New York State, but New York State is pretty big. We are actually 6 hours or 5.5 hours to New York City. We're actually closer to Toronto than New York City. So here's our clinic, and it's called the Soul Care Clinic, Specialized Oncology Care and Research in the Elderly. It was created by Dr. Supriya Mohili about 10-15 years ago. It has grown to a large clinic, as you can see here, and here are the people that we have in our clinic. And the reason I say it's one of the biggest clinic in the country is that we have 6 geriatric oncology. So all of us are trained in geriatrics plus oncology. And then specifically, I'm also trained in hematology. So we all have the expertise in both. With time, people may feel you don't have to train in both, but because we're trained under Dr. Mohili, all of us feel like we have to go through training in oncology and geriatrics. And then we also have other allied health professionals that is in the clinic. So for example, we have a nurse navigator, a clinic coordinator, occupational therapist, physical therapist, social worker, pharmacist, secretary, and a lot of different nurses for the various teams, and also advanced practitioner, as well as study coordinators, as each of us have our own portfolio of research. So we all work with our own research group. So they're often present at the clinic as well. So at any given day, we have at least 5 people in the clinic. And what happens is when patients are in the clinic, we go around and the patient will see each of us and go through the recommendation. So for our specific clinic, there are generally 2 reasons why they are referred to us. And again, we have a consultative geriatric assessment clinic. So the primary oncologist will refer that patient to us, generally for 2 reasons. First is for treatment decision making. So as Dr. Jacobs and Dr. Godiet mentioned, mainly Dr. Jacobs, how the geriatric assessment can guide treatment decision making, and we would perform the cancer and aging research group toxicity score as well as the crash score. And with that, we would make recommendation on whether there's a need to dose reduce the regimen or start with 1 chemo versus 2 chemo, or maybe chemotherapy isn't a good option at all because of how frail they are. So the majority of our consults are on treatment decision making. And then the second most common reason would be identifying areas that we can optimize, and then either optimize them using interventions that we already have, or we refer to physical therapy or occupational therapies for further optimization. So a good example is stem cell transplantation, which I've personally started in the last 2 years, where all patients age 65 and over who will undergo allogeneic stem cell transplantation will go through this clinic. And the goal is not to tell the transplant physician whether they're appropriate or not, unless I feel like they're really frail, but to optimize their health before they undergo the transplantation. So just to remind everyone, when we do geriatric assessment, here are the 7 core components that we looked at: functional status, psychological health, nutrition, comorbidity, cognition, social support, and medications. And in each of this domain, there are specific assessment or battery of tests that we do for patients. So this is a busy slide, but just to show you here, in each of the geriatric assessment domain, we had validated assessment that was previously mentioned by Dr. Golday and also recommended by the American Society of Clinical Oncology. This is a more comprehensive assessment. Many clinics do not have the ability to do all of this, but this was what we use since 15 or 10 years ago. So again, each of this domain, we use at least one tool to assess them, and not one person do everything. That's why we have a multidisciplinary team and we split those assessments among us. So for example, the occupational therapist would actually do the cognitive assessment, whereas the physical therapist would actually do the physical performance tests. And then we also have a packet of self-reported assessment where we mail to the patients prior to the clinic. So they come to the clinic already pre-filled this geriatric assessment battery. On the left here was our traditional geriatric assessment packet or assessment that we still use if it was in-person visit. But because of COVID, we have had to adapt things a little bit and make it briefer. So the geriatric assessment can be done on the phone, but by our nurse navigator. So on the right here is showing how we adapt the assessment. And if people are interested, you can refer to this paper on the Journal of Geriatric Oncology to see how we changed the assessment during COVID time. So just to show the workflow a little bit of how our clinic works. So we have a clinic coordinator and a nurse navigator to go through the schedules and send the packet to the patients prior to the appointment. And then the patient or the caregiver completes the geriatric assessment prior to the clinic visit. We know a lot of people may not be able to complete it at home, or that they their visit was made sort of 1 or 2 days before the actual clinic visit. So we had to provide a shorter packet to them when they're in clinic. So once that has been completed, on the day of the clinic visit, we had different people basically go through the different assessment. So for example, the nurse would meet with the patient. We then had, we usually have a lot of trainees in the clinic, so they would get the history with the patient. Then the physical therapist, occupational therapist, pharmacist, dietitian, social worker would each go in and talk to the patient and then perform this assessment and deliver interventions as appropriate. And usually at the end, the physician, like myself, would go in and wrap up, providing assessment on decision-making and also summarize what the different geriatric assessment interventions are that were delivered by the previous team members. This is an adapted workflow for the telehealth geriatric assessment. What is different here is basically instead of sending a packet to them, we had our nurse navigator call the patient on the phone and complete a brief version of the geriatric assessment. She then documented in the electronic medical record. We don't have a pharmacist on site for this patient since they're not there anyway. So the pharmacist would review the medication and email us regarding their recommendations. We would have the occupational therapists and physical therapists do their assessment on the phone as much as possible, acknowledging the the physical performance test cannot be done on the phone. So we had a video adapted version that we're using. And then on the day of the visit itself, the nurse would start the visit, do the medication reconciliation, and then the physician would join the visit later. Generally, if it's in-person visit, it takes about 2 hours. But if it's a telehealth visit, it's 1 hour on that day itself, because we had more time and chance to do some of this assessment on the phone prior to the actual clinic visit. So that's the workflow for the whole full geriatric assessment. Now, acknowledging that we do not have the resources to see every older adults referred to our cancer center. It's just not possible, even though we have the largest clinic. So what we had also implemented was a geriatric screening tool. So here are the example of the tools. If people are interested, all of this have been validated and are found to be associated with the geriatric assessment, the full geriatric assessment. But specifically, we use the Geriatric 8, which has the highest sensitivity and specificity based on several systematic reviews. So what we essentially did was we created the Geriatric 8 and put it on our electronic medical record. And for people who are not familiar with Geriatric 8, it's pretty simple. It takes about probably between 3 to 5 minutes. It can be self-reported or performed by a nurse, for example. It has 8 questions, and some of this question can be, the answers can be pulled automatically from the electronic medical record. So we had built this in our medical record as shown here. So for example, age is one of the questions. It's not even shown here because we can pull the age directly from the electronic medical record. We can pull the weight, for example. And then what we had done was we trained all nurses, specifically in our institution, not a lot of the blood cancer patients get referred. So we started with this group first. We had asked and trained all nurses to perform Geriatric 8 in new patients aged 70 and over. So the nurses would go through this assessment. And at the end, there's a cutoff for the Geriatric 8. If you score 14 or below, that's considered impaired. So the recommendation is to refer to our geriatric assessment clinic. They don't have to refer, they don't have to follow the recommendation, but it's there if they need some guidance. So this may serve as a first goal for the clinicians or nurses to screen patients and also figure out who can best appropriate the resources at the geriatric oncology clinic. So the workflow is pretty simple. Again, we actually provide prompts to the nurses to complete this. So we screen all their schedules, and then we send an email reminder to all nursing staff to complete this in patients aged 70 and over seen at our clinic as a new patient. All of these results then get saved in the electronic medical record, and the physicians can review this. I'm putting a few papers here just if people are interested in the different models and how they implement it. The first one talks about how we adapt our geriatric assessment to a telehealth format in response to COVID-19. Dr. Soto in Mexico had written a very nice review on the different geriatric hematology programs and those who are in low resource settings. And then there's another group at Ohio State that talks about their geriatric oncology clinic. So I'm going to switch to some of the research that are ongoing right now in our institution, specifically in blood cancer. So here's the overarching goal of the geriatric oncology research program. So personally, I'm very interested in using mobile health technologies to improve outcome in this population. And the mobile health technologies may involve the use of apps, and we also use web-based platform to help deliver geriatric assessment batteries and also facilitate conversation about treatment and advanced care planning. So one example here is, this is funded by the National Cancer Institute, where we have older adults with blood cancer utilize a mobile app in combination with an exercise program. And as part of the intervention, we collect symptoms, we collect exercise data, and then we provide continuous feedback to patients during the intervention period. So while they're going through chemotherapy, and this study focuses on patients with acute leukemia and myelodysplastic syndrome, so sick patients getting chemotherapy, we are trying to introduce this during treatment to prevent treatment-related toxicities such as functional decline that we know are common in older adults with blood cancer. So right now, we have a pilot randomized control trial where we have people either do the exercise program with the mobile health app or an education control. And the goal is to see if this program actually improves physical function as our primary outcome, as well as other outcomes such as fatigue, mood, and quality of life. We're also doing translational research. So we collect blood samples and analyze for some of the biomarkers, which I'll come to later. Because we know symptoms are very common in this population, and because of that, we created an automated symptom algorithm on the back end. And as patients go through the question for specific symptoms, depending on what they pick among the response option, there is an algorithm behind it that take them to different recommendations, either continue doing the exercise or have they received any blood transfusion. And if not, please contact your medical team. If the symptoms are not severe, there are self-management recommendations that are available for the patients to go through themselves. In response to feedback, we also find that older patients like to review videos and on top of written material. So we created some exercise videos that we incorporated in the mobile app as part of the intervention. And in addition, we also created dashboard so that they can compare their exercise data with other participants, and this serves as a motivation for them to continue exercising during the treatment. So as I mentioned, we are also doing translational research. So one of the biomarker that we're very interested is epigenetic age, which is perhaps one of the more exciting biomarker out there to predict biological age and also predict health span and lifespan. So as part of this study, we're interested in seeing if this exercise intervention actually reduce accelerated aging through measuring DNA methylation age or epigenetic age. Other projects that are ongoing is that, again, sometimes resources are limited in how we implement geriatric assessment. So just linking back to my interest in mobile health, can we use an app to facilitate delivery of some of this self-reported geriatric assessment questionnaire? And also this app may also facilitate some of the recommendations generated from the geriatric assessment. So any education materials in response to impairment detected on geriatric assessment, this could potentially be delivered through a mobile app rather than in physical forms. It can facilitate exercise. It can provide fall counseling. So there's a lot that technologies can help, but we just have to make sure that these technologies are tested in older adults and make sure they're feasible for this population. So the other two of the other studies that we're doing right now is given my interest in acute myeloid leukemia, and we know geriatric assessment is generally not incorporated in this population. We had incorporated geriatric assessment along with ways to elicit patient preferences as part of a web-based platform. So the goal is we would do all the geriatric assessment in a way to assess patient preferences, and then we would provide this summary report to oncologists directly. So this is a study to assess whether doing this upfront and then providing the summary to oncologists would facilitate shared decision making. They don't even have to refer to the clinic. We're doing this as part of the routine clinical practice and see if we can improve communication and shared decision making. And then finally, telehealth. With the increasing use of telehealth during COVID, we're also trying to see if we can use telehealth to deliver advanced care planning for older patients with blood cancer. So here, I've just talked about the different research projects. I'm going to shift gear to talk about some of the organizations and how people could potentially be involved. I'm going to talk more about Young SIOG Cancer and Aging Research Group, which I know Beverly, Canin is going to talk more later, and then briefly mention about the observership program that we have. So Ms. Musolino has already talked about SIOG, so I'll skip this. And specifically focusing on young SIOG, which is an interest group, mainly consists of young investigators. And the criteria right now to join this is people have to be within 10 years of completion of training. And as part of the Young SIOG committee or governance, we also serve as a liaison to the different SIOG committees. So it provides opportunities beyond the Young SIOG governance. You can also participate in other SIOG committees. And we're pretty active. We have about 6 members, and here are the things that you could potentially be involved in. So we have an upcoming forum, which is a 1-hour call for people to come on and talk about their research or clinical projects or network. We have a newsletter that just recently came out, I think a few weeks ago, that talks about ongoing activities. There are education webinars that you can participate. And then specifically in terms of writing, we are very active in writing review papers and publishing. So in the last 3 years, we have published as a group 17 review papers. Most of them go to Geriatric, Journal of Geriatric Oncology. We also have perspective papers on conferences as well. And we also write blog posts every 2 months. So if you're interested in contributing, those are areas that you could potentially be a co-author or lead a group of authors to write a paper. You can also participate in task force participation. If we know of your interest, we can invite you as a young SIOG representative on these different task forces as part of SIOG. And to do this, we created a database where we have where we know what people's expertise are. And if you're on Twitter, you can join us on Young SIOG. Just want to make sure we have enough time. Here are some examples of publications that I put on. So we have a variety of interests from hematology to oncology as well as geriatrics. And if you're interested, just get in contact with us. We'll be able to put you in a working group. And this is constant. There are papers that are constantly being written. So I'm sure you can get involved in some way. And then briefly about the Cancer and Aging Research Group, hopefully Beverly will be able to talk more about this. This is mainly based in the United States, but we have more and more members joining. And the mission of the Cancer and Aging Research Group is for any researchers or clinicians who are interested in cancer and aging, you can join for free. There's no cost to this. We have a call every 2 weeks from 2 to 3 o'clock Eastern time, where there's an agenda and people go through a variety of things related to geriatric oncology. As part of this, there is also a young SIOG equivalent of SIOG. We have a junior cancer and aging research group where we talk a lot about how to organize activities for the junior members. And then just finally, in Rochester, we have a research observership program where people from other countries come and visit us. It is mainly for research, so they get to be involved in a research project, and then also shadow in the clinic to learn about how we perform geriatric assessment. And here are the people that we've hosted in the past. And if you're interested, you can look at the website a little bit more. And with that, just want to thank again the organizer for inviting us and members of the University of Rochester Geriatric Oncology Program, and happy to take any question after this as well as through email. Thank you so much.
Thank you so much, Melissa, for the wonderful talk. Actually, you're really our role model, you know, as the young members for contribution in the future for the geriatric oncologist. Yeah, so let's see if there are some questions from the audience. You may also type in the chat or raising the hands.
Maybe I can ask a brief question now.
Yeah,
so
sure.
Great to have you in this meeting, Melissa. And great to see what has been set up at your institution with regard to routine care, but also, of course, your research program that you have presented. My question is, when I look to our country here, in the large oncology centers and hematology centers, they like the ideas of implementing geriatric methods into oncological and hematological care, but so far they have always considered that as nice to have. And they get into under more pressure now with some RCT evidence that more or less force them to react a little bit more. But still the structures to provide, for example, a consultation service in your institution they lack financing resources, for example, in the system. So my simple question is, do you have any tips how to, let's say, further convince the oncologists and hematologists at these centers to cooperate better?
That's if I know the answer to that, I think every institution would incorporate geriatric assessment. So I think I mean I don't have a lot of experience being in a geriatric oncologist. I just graduated probably a few years ago. My opinion is that you have to build a relationship with your colleagues. I did present how wonderful our model is, but there are still quite a bit of people, at least in hematologic malignancy, who are quite reluctant in referring. And the people who refer are the people that know me and know my work and are willing to engage and do that because I spend a lot of time convincing them. So I think building relationship is really important, and always start from something small. So I didn't ask them to refer and do the entire assessment. I started with, hey, let's just let our team screen your patients and do the geriatric aid. We won't even bother you. We'll work with your nurse. We'll start there. And then once we're able to implement the geriatric screening, we then would talk about, hey, now that we've implemented it, we find that a lot of patients screen positive. What do you think about referring to our clinic? You don't even have to do anything. Just put the referral and we'll take care of everything. Even that though, at least in hematologic malignancy, physicians feel a lot of ownership of their patient, and sometimes they don't really want a separate opinion. So breaking that bridge, and again, I that's where I think building relationship is really important. They need to understand what the clinic is about and what they're gonna get out of it. Like they don't want you to tell the patient different things from what they told the patient. So if they feel like the patient can be transplanted, they refer the patient to your clinic and you say, hey, I'm a little worried about transplant. That's going to cause more problem and time from their end, right? So I never say that in the clinic. I just say, hey, this is what we can do to optimize things. And if I feel like they really cannot tolerate transplant, I will communicate directly to the physician rather than to the patient and say, hey, you shouldn't do transplant, because that's just a secure relationship. You need to talk to them, ask what's the reason for referral first, and try to talk to them before you give mixed messages to patients. So I think relationship is really important. Doesn't work for healthcare system as a whole. I think honestly, policy has to change to increase utilization of geriatric assessment, but at an institution level, you really have to build that with people so they trust what you do, in addition to all the research that you're doing to provide the evidence that it is useful.
Wonderful. Thank you. Thank you so much, Melissa, for your great share. So now I think due to time, so we would go to the last speaker, but also very important. I'm actually feel very honored, so that I can invite Miss Beverly Canin, that she's the founder of several very important patient cancer action groups. And for example, he's the former member of the board of the directors of the Breast Cancer Action and patient advocate members of Cancer and Aging Research Group, as Melissa already mentioned. And she's seeking to improve cancer care for the older adults with cancer. And she's also the chair of the stakeholder of the Cancer in Oncology, and also the research for our others. So many important organizations for the patient care. I would say the voice from our patients, friends, and the society is so important, and they are brave, they're powerful, and extremely important. So firstly, please let me to please accept our sincere gratitude and respect to you, Beverly, for you to be here with us. I would really say amazing, Beverly. So really welcome for you to join our workshop, and we are really devastating to hear from you.
Well, thank you very much for that introduction, and also for this opportunity to share with the EUniWelll community my experience as a patient advocate, and specifically as a patient advocate partner in geriatric oncology research. My involvement as a patient advocate began soon after I was diagnosed with breast cancer in the year 2000. I was frustrated because I felt I wasn't being told all of my treatment options so that I could make an informed decision about the next steps. I discovered there was a group of women near me who had just incorporated a community-based survivor-driven organization now called Breast Cancer Options. They gave me the information, support, and courage I needed to make decisions that sometimes went against my doctor's recommendations. From that, my breast cancer advocacy grew from support of individual patients to community education programs, public policy, and legislative change. I continue to serve as a volunteer or consultant in national, regional, and statewide breast cancer service and advocacy committees and organizations. I describe myself as wearing many hats as a patient advocate. The largest hats that is still growing is patient advocate partner in geriatric oncology research. And from there, let me see if I can share my screen. Right, let's go. All right. So as I was saying, one of the largest hats that's still growing is patient advocate partner in geriatric oncology research. This began in 2011 at the annual meeting of the American Society of Clinical Oncology. I had previously been focused only on breast cancer, but noticed a session on prediction, prevention, and treatment of chemotherapy toxicity in older patients. Being already well into the category of older patient, I and an advocate colleague were intrigued and then blown away by the presentation we heard and what we learned. We introduced ourselves to two of the presenters, Drs. Haria and Mohile, and met Dr. Dale. We offered to work with them in any way we could. Fast forward, Dr. Haria invited me to join the Cancer and Aging Research Group, which was co-led by the three of them. I learned by participating that CARG is an internationally respected volunteer organization with a mission. Next slide, please. The mission is to join the geriatric oncology researchers across the nation in a collaborative effort of designing and implementing clinical trials to improve care of older adults with cancer. Significantly, the only requirement for membership is the desire to help older adults with cancer. I became a consultant on several research studies. This was soon after the United States government began earnest initiatives to change the face of cancer care to patient-centered care. Next slide, please. In 2008, the National Cancer Institute published a monograph, Patient-Centered Communication in Cancer Care, Promoting Healing, Reducing Suffering. Summarized in part in the foreword by Robert T. Coyle, it says, thoughtful analysis, these authors, thoughtful analysis challenges the research community to undertake more ambitious studies of communication processes that address the temporal and contextual complexities of cancer care over the course of treatment and survivorship. Then in 2010, the United States Congress authorized creation of the Patient-Centered Outcomes Research Institute, which we all know as PCORI, as an independent, nonprofit, non-governmental organization with a mandate to improve the quality and relevance of evidence available to help patients, caregivers, clinicians, employers, insurers, and policymakers make better informed health decisions. PCORI works with these healthcare stakeholders to identify critical research questions and answer them through comparative clinical effectiveness research, or CER, focusing on outcomes important to patients. As its name suggests, PCORI views authentic patient engagement in research as critical. Next slide, please. So why have patient engagement? Patients can ensure the relevance of the research question to their concerns so as to prioritize the research and funding allocation. Patients can ensure transparency of research activities to avoid harm. Patients are not monolithic. They provide a diverse perspective. Patients can help reduce barriers and strengthen facilitators for accrual. Accrual rates are dismally low, especially among older adults with cancer. Patients can help with recruitment and retention strategies. They can promote dissemination of findings into practice and expand public understanding of science. Next slide. PCORI's engagement principles are reciprocal relationships. From the beginning, it must include patients and other stakeholders as key personnel, define roles and make decisions collaboratively. Fair partnerships, reasonable compensation in line with consideration of time, compensation of others, and overall budget. Commitment to cultural competence and diversity. Co-learning, researchers learn from patients as patients are learning from researchers. Patient-centeredness and stakeholder engagement should be clear throughout the research process. Transparency, honesty, and trust. This may be the most important. Trust is built through transparency and honesty. Next slide, please. I won't go through this. It's a busy slide, but it's very interesting because it's a chart that was created by a patient advocate to show the roles patient stakeholders might have throughout the research process and to identify the differences between a focus on laboratory research and a focus on clinical research. These slides are available, will be available to you following the workshop. Next slide. Initiatives to increase patient stakeholder engagement aren't limited to the United States. Here is an international framework for cancer patient advocacy published in the Journal of Global Oncology in 2015. The aim is to maintain a whole person approach and elevate the patient's values, preferences, and experiences. It emphasizes the need and provides facilitators for building capacity, especially in low-income countries. Next slide. So moving back to direct involvement in research, Dr. Supriya Mohile invited me to chair and collaborate on the development of a stakeholder advisory board for a study that she was designing for submission in PCORI's first year funding cycle. The study was communicating about aging and cancer health, or COACH, and it was at the University of Rochester Cancer Center. The name Stakeholders for Care in Oncology and Research for the Elderly, or scoreboard, was a name we used initially, but it was tweaked with a lot of passion by the group after it was formed, and the elderly was changed to our elders. The objective of the study was to compare the effectiveness of providing a patient-reported geriatric assessment summary report to patients, caregivers, and oncologists versus usual care in improving patient satisfaction with communication about age-related concerns during advanced cancer treatment. Following the study, Dr. Mohile said, this experience of working with patients and caregivers so integrally involved in research led me to pursue a sabbatical to learn mixed methods research so that both I and our team can ensure we are directly incorporating their voices in all of our geriatric oncology research. Next slide. Scoreboard has continued after the COACH study was completed and is now a major participant with the Cancer and Aging Research Group. Next slide. Developing a stakeholder, no. Please, one at a time. I'll tell you when. Thank you. Developing a stakeholder advisory group, in contrast to engaging one or two stakeholders as consultant, involves several elements, and I want to share with you what I believe were the keys to the successful collaborative work that Dr. Mohili and I achieved in developing Scoreboard. I should also note that none of this could have been achieved without strong administrative and clerical support. Next. Early engagement with a stakeholder leader. It is essential to identify an appropriate stakeholder who has the capacity and experience not only to chair the group that is formed, but also work with the principal investigator in defining the appropriate stakeholders for the study and to take leadership in the formation of that group. Next slide. Next. Collaborative partnerships. Successful collaborative stakeholder researcher partnerships have mutually agreed upon roles. Some roles are clear from the beginning. They may be partially dictated by parameters set by the funder, but especially when breaking new ground, others emerge organically during the planning process. Next. Sorry. Recruitment strategies. It became clear during the early planning discussions for the group to have a sense of authentic ownership and cohesiveness. Initial contacts to potential members should be made by me as stakeholder leader, future chair. The University of Rochester team, Cancer and Aging Research Group members, and other contacts were solicited for names of potential stakeholder members. I should also mention that the eligibility for stakeholder, for Scoreboard membership was cancer patients over the age of 65 in treatment or having been in treatment over the age of 65, caregivers of cancer patients over the age of 65, and patient advocates who had a demonstrated interest and experience in working in cancer and aging. I was then responsible for outreach. Next slide, please. I did an initial telephone interview with every potential candidate, making notes for Dr. Mohili and select members of the research team. If potential candidates were interested, they were asked to complete and return a simple profile form, after which another call would be made for a conversation with me, Dr. Mohili, and again, select members of the research team. If the mutual decision after that call was to continue the recruitment process, the candidate was sent additional materials. Next. The materials preparation was a truly collaborative process involving different members of the team and myself. One of the most important at this stage was next, an overview. The overview was actually a packet of materials, including the history and primary aim of the PCORI grant, Scoreboard's mission and responsibilities, an introduction to Dr. Mohili, the grant stakeholder engagement plan, various other background material, and supporting documents. The candidate was also sent an agreement document. Click next slide. Roles and responsibilities were included, and as well as the responsibilities of the University of Rochester PCORI funded research team. The administrative support staff processed the signed agreements. Next. And finally, there was a welcome meeting. Though long before it became a norm because of the pandemic, our meetings were always held in webinars because our members were scattered across the United States. The initial meeting was to get to know one another, to work out any glitches and address. The first concern was the discussion that I mentioned previously about the ways we refer to our older population, and complete rejection of the general use of the term elderly. But that was just a beginning. Next slide. Here you see some of the contributions of Scoreboard to the COACH study, taken from a manuscript evaluating the association of frailty with communication about aging-related concerns between older adults with advanced cancer and their oncologists. And that was by Gilmore et al. And published in Cancer in 2021. It details the evolution and role of Scoreboard in the study. So Scoreboard worked, and these graphics were designed by one of the Scoreboard members. Scoreboard worked intimately with the researchers and guided the research process from protocol development to dissemination of the positive outcomes of the largest randomized geriatric assessment clinical trial to date. We've shown not only that engagement with Scoreboard was feasible, but also that this engagement resulted in tangible and invaluable benefits for both the research team and patient partners alike. And actively engaging patient partners should be an essential component in the development, conduct, and completion of all clinical research, was the conclusion. And I thank you. Next slide. I kind of rushed through that, but I hope that I stayed within time. I saw we were running short of time.
So thank you very much. I quickly have to overtake my the possibility to say thank you for this, because this is a very rare participation in scientific meetings. And this is really appreciated and also missed many times. And so
well,
you rushed.
We need to do more of this. And you at SIOG have been, I've been very outspoken at SIOG and presented last year. Which is a big thing. And it's my goal, my mission, I will let you know right now, is to broaden SIOG's work with patients and patient advocates.
Thank you so much. I give you the Barry. You overtake the moderation immediately. But I have a question to for Beverly again. Are you connected? So do this your organization talk also to other patient disease organizations, so geriatric cardiology, geriatric neurology? Are you also connected with other diseases organizations or not?
Well, I am, as I said, I'm a breast cancer survivor, so I still have strong links to breast cancer advocacy. But it broadened in terms of other diseases in the work with the Cancer and Aging Research Group, since they do, as far as we know, there is no other group dedicated to research for cancer and aging research, no other advocate group that we know of. And actually recruiting, we will be expanding. CARG has received a very impressive grant from Rising Tide, which is going to involve 5 separate studies, each with a different disease focus, but all unified by using the geriatric assessment. And we will be recruiting more members because we don't have the capacity with the existing members to respond to all of the requests for our involvement. And it will be very interesting to see how that outreach works and engage recruitment, because I know, anecdotally, I know a few advocates who have said, you know, they've been interested for a long time in cancer and aging, but they didn't have a way of focusing that interest. And of course, one of our limitations is even with the expansion, we still will be a small number, and trying to bring diversity of all kinds into a small group is not that easy sometimes.
No, sure. Great, thank you very much. So Barry, back to you.
Okay, yeah. So I think because we are already a little bit short of time here, we're already a few minutes over. I just try to finish very fast. So I would say, of course, so back to our workshop today, and also back to our seed funding project. So why we have such a project, I think it's also very nice that we are able to invite all the excellent distinguished speakers here to share their ideas, concept with all of us today. So as also in the end, we realize that cancer in the elderly is really the challenging and also the barriers, but also provide a lot of opportunities. So I think from all of us, right, patient is really important. I mean, of course, we do have the healthcare powers and also with the support from the societies. So in the end, I mean, the patient are all of us, right, and also our families, our friends. So they are be centralized, I would say. And also why we have the seed funding project is also, as Professor Polidori mentioned, education is really, really important. So education and training, not only for our, I would say, future powers, right, for the medical student, which we initiate this project, but also for the public and also for the patient in the end. And so therefore, for in the past year, so we also want to share with you that we are able to initiate this project together with multidisciplinary and interdisciplinary. So not only in the colleagues from the medical field, but we are also able to have the colleagues from the informatics, education, and economics, for example, to input all the power together. So each of our partners make their record in their field to make the E-class. So this is also, I think I didn't list all, but as you can see from Leighton, from Florence, from Birmingham, from Venice. So we have the great partners here, as well as the power from the University Hospital of Cologne, from my supervisor, from Professor Polidori, and my great partner supporter, Dr. Evelyn Plumper, and also my colleague team from the surgery, as well as my student, Nani. So she really supported me a lot for this project, as well as in the end, I mean, for me, I really want to learn from geriatric oncology. So therefore, it's also very great that due to the project, we are able to connect with the excellent organization like SIOG and the CARG, and also with all this voice together. So, I mean, during the pandemic, it's very challenging, but we are able to make this mini movie somehow to meeting Doros. This is like we also invite the Claudia, the professional actress, to perform the old cancer patient with pancreatic cancer. Then she tried to talk with our student and also try to talk with our physicians to see how was this kind of future communications between the patient and also the healthcare. So hopefully later on, I mean, hope all of you still focus on our project. We hope that we can release these small movies in the few weeks. And yeah, so I would say this is only a seed funding. We hope that our project and our small workshop can give you a seed concerning of this topic, because I'm not a geriatric oncologist, you know, so therefore for me, I'm very happy that with this great opportunity, we can learn this together. And yeah, so in the end, I would say one word I get from this song from Linkin Park is that who cares if one more light goes? So well, I do. So here I would say, well, we do. So I mean, everyone counts. So I mean, cancer is already very complicated, and aging was also very complicated. When putting all these two together, for me, I mean, also for all of us, right, it's very, very challenging and difficult. But I think it only can achieve that we can work together. So yeah, so this is what I really appreciate all of our speakers and our partners and our audience here. So because I feel that you are here because you are highly motivated to support us. Yeah, so thank you very much.
Yes, also from my side, thank you very much. thanks to the speakers, to the great speakers of today. Thanks for the audience, to the audience, and also the many feedbacks now on the chat. We have the registrations and the recordings also of this meeting, so don't hesitate to come in, to reach out to us and ask questions or ask for contacts. It will be key that we keep in touch and exchange further on. So write me or Beverly through your institutions, and let's keep working on this. And thanks a lot, and enjoy the rest of the week and also the weekend, and see you soon. Bye-bye. Thank you.
Thank you. Bye-bye.